Good morning, everyone. I'm Patty Holland with Corporate Health and Wellness Association, and we are very lucky to have with us today to discuss vulnerable populations and case studies to learn from is Dr. Susan Frampton, who is a medical anthropologist and is the president of Planetree International. And it's a not-for-profit advocacy and membership organization working with an international health care network and to implement Planetree's comprehensive person-centered model. In other words, Planetree puts the patient first. Dr. Frampton's work to establish structures for organizational excellence and patient experience has culminated in the only global certification in person-centered care. And that's what we're going to learn about when it comes to vulnerable populations. So I'm going to turn it over to Dr. Frampton. She's going to give us a wonderful presentation and take it away.
Thank you, Patty. Appreciate the introduction. And it's wonderful to have an opportunity to talk with folks today about an aspect of our response to the pandemic that I think is really critical and perhaps not getting as much attention as it needs at this time. As Patty said, Planetree's focus is on person-centered care, on patients and their families, and the partnership that we need to continue to support as them being members of their healthcare team. And that's become more and more a challenge as the seriousness of the pandemic has spread. And so I want to focus on that important quality of keeping healthcare human and making sure that the way that we are dealing and working with patients and their families, as well as our staff, supports that human-centered care, because I think that's even more important right now, perhaps, than ever. And so I'm going to talk about some of what we've been seeing in the field at hospitals, at healthcare centers, at long-term care centers, some of the policy changes that are taking place, some of the unintended consequences of those policy changes, and then some practical strategies that can be used in healthcare provider organizations, as well as more generally in the public, to respond to the COVID-19 outbreak in a way that does continue to focus us on a balance between safety and compassionate care. I have some resources to share with you as well, with some links that I'll encourage you to follow up on if you'd like more information. And so let me go ahead and also just make sure that people understand that, yes, I am a medical anthropologist and I work for a patient advocacy organization, but I'm not an expert in infectious disease or pandemics. I'm, like most people, looking at credible sources of information to keep up with what is happening around us. And so the comments that I'll share with you today, the ideas, the strategies are based on current knowledge and recommendations as of today, and they're not meant to override any local regulations or requirements, because there may be some location-specific guidelines that people must follow. I think one of the most important things, again, is to underscore the need to spread credible, reliable information. And I often point people to both the World Health Organization website and the CDC website. And there, again, may be some country or region specific sites as well that you can rely on for good scientific, fact-based information. This is not a time to be relying on Facebook or social media. And while we may use those formats to keep in touch with loved ones, that's not where the most credible, reliable information comes. So I would encourage all of us to be advocates for credible, reliable information spread. There are constants of being person-centered care, or being person-centered in your care, and that commitment. It always begins with quality. So none of the recommendations that we make are meant to in any way impact that very important foundation of quality and safety. But it is just as important that we continue to focus on how we provide care with compassion and in partnership with patients and families. Many of our healthcare systems over the last decade or two have come to reinforce the importance of a person or patient-centered healthcare system, which means we plan and provide care in partnership with patients and their families. We don't do things to them, we should be doing things with them. And that includes at this very critical time. We've already begun to see some very serious unintended consequences of some of the restrictive policies that are being put into place, particularly around family access. When you think about your own experience, if you've been a patient or you've had a loved one who's been a patient, you know that it's a very vulnerable time. And even more so now in the current situation with the pandemic, people are fearful. They need emotional support, often as much as physical support. And so when we begin to see these very restrictive policies put into place around families having the ability to be there to provide that support to their loved one in healthcare settings, these are the kinds of things that are happening. We're seeing families deciding to take elderly loved ones out of long-term care environments when they institute a no visitation policy in those environments. We are hearing of women in labor driving hours outside of their own area to hospitals that still allow their partner to stay with them during childbirth. We're seeing more women looking into home birth as an option for the future, fearful that they won't be allowed to have their birth partner with them. We've heard of parents that are reluctant to take their children to local emergency departments, even when they have signs or symptoms that would indicate that they need to be in the emergency department because of fears of being separated there, as some organizations have implemented no parents being with their child in the emergency department. And there is just a growing general reluctance to seek care when needed, in part because of these kinds of restrictions. People are afraid. And so I think, again, we need to be looking at the evidence base for visitation restrictions or family access restrictions and balance safety with the evidence base. And so we should be certainly doing routine screening of all visitors to a healthcare facility. And of course, that includes our staff that provide care there, as well as family members or community members who are coming in to visit a loved one. We need to be really clear about setting expectations for visitors in healthcare settings around the basics of hand hygiene, cough etiquette. We need to be providing personal protective equipment if it's appropriate, given the situation in that healthcare center. And there are times when limiting or restricting visitation will be clinically indicated. And so we're not saying as a blanket statement, we shouldn't be ever restricting visitation. We do need to be practicing more thorough and comprehensive evaluation of visitation policies in many cases. However, we do need that balance. We need to understand that there's a human toll to isolating patients or residents in long-term care and not allowing them access to their loved ones, particularly in some of the special cases that I've mentioned. And this includes, of course, end of life. Just the other day, as I was driving into work, I heard a report on the radio of a father standing out on the sidewalk of a hospital, looking up at the ICU windows, knowing that his son was in the ICU dying alone. So there is a human toll. So we do need to be very, very careful about the way that we set these restrictions up, that we continue to monitor these, and that we maximize our ability to still provide compassion and empathy, even as we may have to be enforcing some of these new restrictions. And so I do want to take a little bit of time to talk about how can we be more sensitive to make sure that caring is visible as we talk with families and patients. And right now I'm hearing a lot of these kinds of words being used around our response to the pandemic, around some of the, again, restrictive policies we're putting into place, that we are locking things down, that we're at war, that when someone with symptoms comes into the emergency room, they're a hot one. There's a lot of no this, no that. These are words that frighten people. These are terms that frighten people. There are other ways that we can be using language to describe what's going on, but to do that in a more positive way. And so think about what you're intending to convey to someone and how you're languaging that. And these are just a few examples provided by our colleagues at the Language of Caring, whose total focus has been on how we communicate with compassion and empathy. And so when we hear ourselves or staff saying something like, I'll try, people hear, not sure I can do that. Or it's our policy. What people are hearing is, that's the way it is, take it or leave it. You have to, I make the rules, you follow them. So think about how to sensitize staff who are communicating some really challenging things to patients and families, and how we phrase those. We can make caring visible in the way that we language things. So using more positive phrases, what can I, what I can do for you, or yes, I'll work on that, or I can certainly help you, to really make people feel you're here for them. This is a tough time, it's extraordinary circumstances, but I recognize you and your needs as a human being, and I want you to know that I'm here for you and with you. Making caring visible, if you think about it in sort of breaking down communications into 3 essential elements, when we want to make sure we're communicating with empathy, we need to encourage ourselves and our staff to recognize what is happening here. What are we feeling? What is the person we're dealing with feeling? And then to communicate based on that in a way that supports them. And here's a very specific example, because this is a scenario where, again, we're seeing play out all over. A visitor who comes in, who's screened, as of course they should be before they come into a healthcare facility, and they screen positive for a slight fever, even though they've had no symptoms of coughing or shortness of breath. So they were coming there to see a loved one in a healthcare facility. They have this slight fever. They didn't even know about that. And you have a staff member that then has to react in this situation. The first step is to recognize that this person is likely feeling angry, feeling victimized, feeling surprised, feeling uncomfortable. You need to also recognize your own response in a situation like this. You may be feeling very protective of yourself and others in the facility, but you also hopefully are feeling some empathy for this person who wanted to be there for their loved one. So one way to communicate around this in a supportive fashion is to say, hey, I am sure you must feel very frustrated that you're not able to see your loved one right now. And I want to assure you that your mom, your loved one, is as well as possible, that our patients here are top priority. We're going to work together on resolving this situation. And let me offer some support. Let me offer some options for virtual visits, other ways that you can still see your loved one, interact with your loved one, but keep your loved one safe, keep you safe, and keep all of the members of our staff in this facility safe. So we can communicate challenging messages with empathy. One of the things that we've been asked by many of our affiliates is for sample language around visitation policies that are recognizing this need for a little more sensitivity so that our staff have guidance as well as our patients and visitors. And so this is one example that we worked with one of our affiliate sites, Griffin Hospital, it's a community hospital in Connecticut. And they have taken temporary precautions. And I think it's important for people to recognize this is a temporary situation. It's not how it's always going to be. But right now, we have to take some temporary precautions in order to protect you, protect caregivers, protect our community. We want to make sure that we're tying some of these additional steps, like screening people before entry, to their own safety and the safety of their loved ones. When we get down to some of the details on the actual visitation guidelines, we may want to use words like, you may enter through this entrance versus saying, enter at the front door only, or don't enter through the side entrance. We can language this in a more positive, welcoming way. If we're restricting the number of visitors, we want to make sure that we're communicating why we're doing that, that there may be special circumstances that we'll work with you on, for instance, end of life, or when there's a pediatric patient and both parents want to be with their child or during childbirth. Again, those special circumstances that we're not laying down the law and saying there's no exceptions, that we'll work with you. Because people want to feel that they are being treated as individuals. Using words like please to soften a guideline such as remaining in your loved one's room, instead of saying you must remain in your loved one's room, to say please remain in your loved one's room. And when we are not able to accommodate visitation, to supply other suggestions of how they can connect with their loved one. And certainly people are getting very, very creative around the use of apps, the use of FaceTime, of WhatsApp, etc., in order to be able to communicate with loved ones in healthcare facilities when they can't be present with them. And then as a final note, making sure that people understand that the situation is fluid, it's changing, we're learning more all the time, and that we're going to continue to assess the situation and adjust policies in a timely manner based on current knowledge, so that people don't feel that this is now going to be the policy going forward, that we'll never be able to see our loved ones when they come into this facility. We want to guard against that sense that this is a permanent situation. Other visiting considerations that we've encouraged people to think about are some of the age restrictions. We're seeing minimum age restrictions being placed on visitation. 21-year-olds, 18-year-old or under not allowed in a facility. And our question would be, where is the evidence that is supporting an age-based restriction? Certainly, there are times when that type of restriction is not reasonable to enforce. Obviously, there are some young parents that are younger than those age restrictions may be. In the case of a terminally ill grandparent, it may be very important that a grandchild be able to be there. So think about why we're enacting certain restrictions. And understanding that in many cases, age restrictions were tied to the assumption that children are in school, they're in large group settings where there's a lot of interaction and opportunity for infection. Many schools now have closed. Many families are sheltering at home, so there's now a little more limited exposure to others. So think about those age restrictions. Think about also the community that you are in and whether there's active community spread going on or is the virus contained. And then also thinking through the restrictions that we do put in place, how will we enforce them? How will we roll those out? How will we help our staff to understand the why behind these restrictions so that they're in a good position to explain this to questioning loved ones? Other questions that we've gotten from organizations that we work with have been about some of the patient preferred practices that they've put into place and whether it's still safe to do these things. So team rounding, bedside shift change has been a couple of the practices people have asked about. We were very strong advocates of things like bedside shift change, where the nurse going off shift and the nurse coming on meet with the patient at the bedside to talk about what happened in the prior shift and what the plan is for the next shift, and does the patient have any questions, any input into that. In a healthcare setting, certainly the staff should be or will be wearing adequate personal protective equipment. And so having two nurses at a bedside doing that, that handover certainly seems to be a reasonable practice to continue. Certainly if there are additional concerns to do this perhaps with a virtual format, if one nurse perhaps is at the bedside and has an iPad and can connect virtually with the nurse who was on that prior shift, if precautions for additional safety are warranted, but making sure that we are still providing as much information as possible to the patient and the patient's family, especially at this time when fears are heightened. We've also heard a lot of concern expressed by volunteers who are used to coming into the healthcare setting and work with patients or work in different departments. They're feeling the impact of restrictions on their ability to continue what could be very, very important work for them. So think about what other options are there for our volunteers. Are there still administrative, non-patient connected duties that they can help the hospital or the long-term care center with? Can they be involved in virtual work? Can they help us to staff call-in centers, for example? So getting creative about how we can still stay in contact with volunteers who are very, very important supports in many situations. Many of the organizations that we work with also have patient and family partner councils. So partnership councils who are used to coming into the facility, meeting as a group, and being good partners to the organization and helping them to continue their commitment to being person-centered by engaging the community in this way. Again, getting creative about continuing that relationship with those important councils, those important patient and family advisors, perhaps holding virtual meetings, for example, making sure that as we do change policies and practices, that we continue to invite the input of these very important advisors, that we don't assume that we know what's best when we're talking about the emotional health of our patients, of their family members, and of the community, but that we're asking for their input all along the way. Some considerations in caring for the most vulnerable populations, and I'm thinking here about elders, again, in long-term care facilities, individuals who may be in group homes, individuals with behavioral health challenges. Certainly technology, as I've mentioned, can be very powerful, and to the extent that we're able to support and enable that in vulnerable populations, that can be one set of answers. Using social media to communicate with families and friends, obviously that's a very appropriate use of social media. Helping our staff to create meaningful one-on-one interactions while maintaining safety in terms of physical distancing. Finding ways to connect with individuals who may be confined to a room. For instance, in many long-term care centers, we're beginning to see policies that restrict the resident to their own room and are not allowing people to congregate in public areas. How do we make sure that we are checking in on a regular basis? Perhaps we use volunteers who can call in or use apps to interact with people so that they don't feel isolated. because there is a real risk of the emotional toll taken on these individuals due to isolation and that sense of being left on their own. So making sure that we're really being very sensitive, very creative about the way that we support patients, and also, of course, support our own staff, because it's very important for us to acknowledge this is a stressful time for our employees, and we need to be flexible with them. We need to be supportive. People may need to have additional contact with their loved ones at home. They may need a little more flexibility around their scheduling. And so there are many things that we can do to help support our staff as well. Here are a number of different resources that you may want to check out around strategies for caring for our caregivers. So please do take advantage of those. So I want to end by wishing you all the very best at this very challenging time. Be safe, be well, and know that you're appreciated for the work that you're doing.